Hi, we're going to be talking about ectopic pregnancy. This is a diagnosis that affects around 1% of all pregnancies, and it's potentially life-threatening. There's up to 2% mortality associated with it, so it's considered a real gynecological emergency. Basically, an ectopic pregnancy is any pregnancy that happens outside of the uterus. Usually these are going to be tubal pregnancies in the ampulla, isthmus, or cornea. It can also happen in the cervix, and it can also happen in the abdominal cavity. The real danger of this, of course, is a rupture of a tube into the peritoneal cavity, and that can cause severe bleeding, hemorrhage, sepsis, death. There are some cases of ectopic pregnancies that have gone on to deliver a healthy baby, but it's very rare, and in normal circumstances that will never be allowed to even take place. So most of these girls or women are going to present with abdominal pain. That is the major presenting symptom. Most of them will have amenorrhea, and at least 6 to 8 weeks of amenorrhea, and about half of them will have vaginal bleeding. And then they're also going to present with some of the normal discomforts that come along with pregnancy. They'll have tender breasts, frequent urination, and nausea. So the physical exam is important in diagnosis. You want to palpate the adnexa and cervical areas, and cervical motion tenderness will be most likely noted. Mild uterine enlargement on bimanual exam, a low-grade fever, orthostatic changes, and then the labs and imaging we'll talk a little bit about in diagnosis. So the differential most common is the threatened abortion, heterotopic pregnancy, appendicitis, UTI, pelvic inflammatory disease, kidney stones, diverticulitis, ovarian tumor or cyst, endometriosis, and leiomyoma. So on this list, we have a couple that are potentially life-threatening. Appendicitis could be, diverticulitis possibly could be. And diverticulitis is going to be mostly in a different age group, so that's not going to be a big overlap. But there's just a couple of things on this list, including ectopic pregnancy, that are important to make sure that you rule out. So we make sure to avoid any mortality. So the way we diagnose this is beta HCG test is important. So this shows up after 8 days of pregnancy, earlier than you're going to have any symptoms from an ectopic pregnancy, most likely. And beta HCG doubles every 2 days. A transvaginal ultrasound is going to be very important in the diagnosis. So you can use this as a diagnostic alone if you can see a yolk sac, an embryo, or an embryonic heartbeat. So if you catch those things outside of the uterus, then you know you've got a ectopic pregnancy. Now in other cases you might just have a elevated beta HCG with some of the symptoms that we mentioned before, like abdominal pain, but you can't find any fetus or any embryo in the uterine cavity. So in that case, the beta HCG plus symptoms with a negative ultrasound basically can be diagnostic as well. Progesterone levels are checked, but I don't believe they're necessarily diagnostic. And in some cases, the diagnosis will be made on curettage. Doppler and laparoscopy can also be diagnostic. So these are going to be cases, laparoscopy, that's going to be a case where you just can't figure out what's going on, and so you have to go in and do an exploratory laparoscopy, and then you find the ectopic pregnancy. So this can be treated medically. Methotrexate is, of course, a drug used to stop basically anything from growing, but it's used for abortion in some cases, and it can be used for ectopic pregnancy. You don't want to use it if a patient is hemodynamically unstable, if there's any type of impending rupture, because you're not going to have time for this to be effective before you have a rupture. You don't use it in immunodeficiency because it's going to decrease your white count, your immune system. You don't use it if people are allergic to it, obviously. In heterotopic pregnancies, you don't use it. Breastfeeding, you don't use it. It has some pretty serious side effects, including immunosuppression, but a lot of others, GI problems especially. Mifeprostone can also be used, and in some cases you'll kind of wait it out, but that's going to be the rare case. So surgically, many of these are going to be handled by a salpingostomy. So what they do is go in and make an incision in the tube or wherever we find the ectopic pregnancy, and then they sew it back up. But the scarring that's associated with that may cause an increased risk of future ectopic pregnancy. So in other cases, they're just gonna cut and remove that area of the fallopian tubes. So in those cases, obviously you'll have one less route for sperm to travel to fertilize an egg, and one less route for an egg to come down. And so you could have a decrease in fertility, but it's indicated for uncontrolled bleeding in severely damaged tubes, recurrent ectopic pregnancy, large ectopic pregnancy, and when permanent contraception is desired. So some of the images that I used here were taken from Wikimedia Commons. They're in the public domain. And if you have any suggestions, please email me at kendrick@themedschool.com or leave a comment below. I want to make sure that these are valuable for those who watch it, especially medical students in their 3rd and 4th years. It has an overview of ectopic pregnancy or whatever subject we're handling. So please give me feedback on what important things I might have left out or what incorrect information I might have given. Thank you.